Hey guys, we're going to do chapter 26 in your book, Respiratory Assessment. It is on page 475. You need to take a listen and realize that you are responsible for the content that is in this chapter, especially the respiratory assessment techniques and the diagnostics and the gerontological changes that could occur. Let's get started. Just a reminder of what you need to do. Some things on your own, such as the anatomy and physiology. Fungal infections are on your own. They're on page 533 to 34. Make sure you listen to this, explain everything. Make sure that you look at slide 4 and understand what diseases we're covering during the respiratory module. And make sure that you listen to the YouTube video on oxygen therapy. Also, if you feel like you need additional information, go back to your fundamentals book, and on page 851, it lists the various kinds of oxygen therapy. This, too, is material that you will be held responsible for. So what are our objectives? That you'll be able to understand the structures and functions of the upper and lower respiratory tract system, know the diagnostics, be able to explain them to a patient and their family. Explain the patho for the various disease processes we're going to do in respiratory, and then be able to look at these disease processes and outline medical management and nursing management in taking care of a patient that would have these issues. These are the diseases that will be covered, and just realize that we will go over the care of the patient with asthma, COPD, and tuberculosis. On your own will be obstructive sleep apnea. So actually just remember that obstructive sleep apnea will be on your own, and the respiratory system and fungal infections. Okay, if you look at page 491 or 481, and then there's a table, 26-4 goes over changes that occur as we age. Talks about structural changes such as the fact that the chest wall stiffens, you have a decrease in recoil and compliance, an increase in your AP diameter, decreased number of functioning alveoli, decrease in muscle strength. What does this lead to? It means that we have some change in appearance. They're more likely to look barrel chest, have a change in the appearance of their back, not be able to breathe as deeply, have thicker mucus, just decreased breath sounds, especially in the bases. We get to defense mechanisms, then overall elderly have a decrease in their immune system and antibiotic production, decrease in the cilia function, and they have a weakened cough reflex and decreased sensation in their pharynx. This leads to increased risk for respiratory infections and also aspiration, which could potentially lead to aspiration pneumonia. And then as far as respiratory control, elderly have a decreased response to hypoxemia and hypercapnia. Now, excuse me, what we need to remember is hypercapnia is an increase in CO2. Hypercapnia is an increase in CO2. And so it takes a greater abnormal value to produce an altered respiratory rate. All right, so then we start to look at past medical history, kind of break it into upper versus lower. Upper would include, repeated episodes of strep, sinus problems. Lower would be any issues with COPD or pneumonia or tuberculosis. You want to ask specifically about medications that they might take to treat respiratory issues, both upper and lower. And then ask about surgeries, and once again, focusing on upper versus lower. If you look on page 483, it talks about the functional health considerations. These are things that we need to ask about, specific questions. So for instance, when we look at health perception, health management, what's their daily activities and how are their breathing problems associated with these activities? And how Do breathing problems interfere with their ability to take care of themselves? And have they had a pneumococcal vaccine? Elimination. Does your respiratory problem make it difficult for you to go to the bathroom? Does it cause increased dyspnea? Such as sleep rest. Do you have issues that cause you to wake up during the night? Can you lay down flat? If not, how many pillows? Do you have to sleep up in a chair? So you guys need to read through these, okay? Genetic alert is on the bottom, and it talks about the fact that there is obviously a genetic link with cystic fibrosis. That also there can be an increased incidence of COPD if a patient has a deficiency of the alpha antitrypsin protein. That secondhand smoke is a major risk factor for COPD. These are some of the genetic alerts that you need to be aware of. Okay, we want to go ahead and do our respiratory assessment. So if you guys are following along, we're on page 485. We need to collect some objective data. So yes, go ahead and do vital signs and start your inspection. Certainly you can inspect the nose, the mouth, and pharynx if needed. Check your neck, make sure it's symmetrical. Check the chest and the lungs. What we're mainly looking for is any kind of respiratory distress. So is the patient tachypnic? Are they using accessory muscles? Is there symmetrical chest wall movement? What is the AP diameter? Patient's AP diameter should be 1 to 2. It becomes abnormal, and we call it barrel chest when the patient has a chronic respiratory condition that causes hyperinflation, such as COPD. So we want to look for AP diameter. We want to look for any abnormal breathing patterns. Those are listed on page 486, and you need to review those. Next, your book talks about palpation, and really palpation is more so for the advanced practitioner. And so we're not going to spend much time here. You can check to make sure that the trachea is midline, that there is just through inspection normal chest movement. Your book talks about fremitus, and it talks about palpating for fremitus, but again, this is an advanced practitioner assessment technique. It then moves on to percussion, and it talks about percussion and how percussion checks for density or aeration, and again, this is more so for an advanced practitioner. Then it talks about auscultation, and certainly auscultation is something that we're quite familiar with, and we just need to review auscultation from what you guys learned in MP1. I will say if you turn to page 489, there's a table, and it is table 26-8 called Respiratory Assessment Abnormalities. And so this is something that you would just want to make sure that you understand what these mean. And especially the auscultation, what fine crackles, coarse crackles, rhonchi, wheezes, stridor, and absent breath sounds are. Okay, so this is showing you a picture that's in your guys' book, and it's showing you all the different points for auscultation, but let's be real. Most patients cannot tolerate this many points of auscultation. It is great if we can do anterior, lateral, and posterior breath sound checks on patients, but often they are too fatigued, especially if they have a chronic respiratory illness. So we go to what we consider the zone of information, which would be posteriorly, and it would be in the lower section. And so if we're going to go posteriorly, then we're going to go in this area right here, if that's all the patient can tolerate. And just remember that if the patient has some rhonchi, you need to stop, ask the patient to cough, and often this will help clear the abnormal breath sounds. Again, just another review, very similar to page 489, talking about what crackles are, giving you a description of crackles, doing the same for rhonchi, and doing the same for wheezes. They do have different sounds. There are many different
videos that you can find on YouTube that help you. Also remember, in the lab there is a mannequin that has various breath sounds that you guys can listen to also. So you need to understand what these sounds are like, and you need to understand who might have them. So for instance, a lot of times asthmatics have wheezing, a lot of times smokers or chronic COPDers have bronchi, or people who have bronchitis. A lot of times people who have pneumonia have crackles, or people who have atelectasis. And so we need to understand how these breath sounds sound and what they could possibly indicate. All right, so diagnostics start on page 491. Just a reminder, there is a YouTube video posted on the concepts of ABGs, and you guys want to watch this. It tells you how ABGs are collected, and it also goes over the basic interpretation of ABGs. The top of page 491, you guys should be familiar with those studies. We get down to the bottom of the page and it talks about sputum studies. It talks about culture and sensitivity, and certainly culture and sensitivity is no different in that it just needs to, or it helps us to diagnose exactly what type of infection that the patient has, and is the patient on a antibiotic that would be effective. And so culture and sensitivities, really sputum samples in general are best done in the morning because the bugs have had all night to cook, and then the patient can cough them up and expectorate in the morning. It talks about acid-fast smears. Acid-fast smear is actually checking for the mycobacterium that causes tuberculosis. It is a 3 early morning sputum collection, and if someone is having AFB sputum collections, then they should be on isolation for possible tuberculosis. A cytology is looking for the presence of abnormal cells that could indicate malignant conditions such as lung cancer. And so when someone has its cytology collection done, doesn't matter if it's sputum, blood, pleural fluid, where it's at, we're always looking for the presence of abnormal cells that could indicate possible malignant cells. If you flip the page and you look at page 492, then you guys know already about your typical chest x-ray, CAT scans, MRIs. There are a couple of different scans, though, that you've probably not heard about yet. One is called a VQ scan, which is a ventilation perfusion scan. This is a 2-step test, okay? So 1, an IV radioisotope is given to the patient to assess for perfusion, and 2, an inhalation isotope is actually given, and it is checking for ventilation. And so it is a 2-step test, and typically this is used to see if a patient has had a pulmonary embolus. A pulmonary angiogram, anytime someone has an angiogram, then this is a essentially a scan in where there is a catheter that is threaded through an artery, and through that artery a patient is given a contrast medium, and they're looking to look for perfusion. Once again, typically it is done to check for a pulmonary embolus. So you have several considerations, and 1, is the patient allergic to contrast dye? 2, can the patient's kidneys handle contrast dye? 3, when the patient comes back to you, they have a puncture site, typically in their groin, that needs to be watched. So postoperatively, these patients have to have their blood pressure, pulse, and circulation distal to the injection site watched, and make sure that there's still good perfusion of that extremity. Next is a bronchoscopy. A bronchoscopy is a type of scope, and so the patient who's going to have a scope is going to be MPO, and they're going to have to sign a consent, This scope actually goes down through the patient's mouth, typically, goes through the trachea, and then goes down into the main stem bronchus and can look at both sides of the lung. What happens is the scope, or all scopes, have actually 3 channels, and these 3 channels, I'll try and draw, but you guys should know early on that's not my strong point. This channel, for instance, would have the light. Okay. This channel, for instance, would allow suction and irrigation, so when you saw like mucus, you could suck it up. And this channel would allow for the passing of instruments. Okay. So for instance, we're able to see that this patient has a mass in one of either the left or the right side, and they can see this on a TV screen. The scope itself is connected to a screen in which everybody can see then what's going on. And so through the port that allows for instruments to be passed, you can actually pass a set of biopsy forceps right through there, and you could take a piece of this and send it off to lab for cytology to see exactly what's going on here. And then if this area became bloody because you took a piece of tissue, then you could actually go ahead and squirt water down the suction port and then suck it back up to hopefully clear it up. So that is a bronchoscopy. When a patient comes back from a bronchoscopy, you also need to make sure that they can swallow, that they can actually feel their swallowing before you go to give them something to eat or drink. And so typically we want to start off with water, just in case they are still numb from the procedure. You need to know what happened during the bronchoscopy, because if there were biopsies taken, then of course the patient could have some blood-tinged sputum postoperatively. Next, on page 493, it talks about a patient having a thoracentesis. A thoracentesis is where a practitioner inserts a needle into the patient's back on one side and actually drains off fluid. So a lot of times pleural fluid will accumulate in an excessive amount, and as you can see, when that happens, then it stops expansion of the lung. And so typically this patient is short of breath. And so we go in there with a needle, and the needle then is connected to a bag, and once the pleural cavity is accessed, then the pleural fluid can be drained into a collection bag or tubes. Gradually this allows for re-expansion of the lung as the excess pleural fluid exits the body. Typically the best way, if a patient can tolerate it, is for the patient to sit up, sit on the side of the bed and lean over a bedside table, and then this draws all the fluid down and makes it easier for the fluid collection. And so this is done just under a local anesthesia, so the patient's awake and the patient needs to be able to cooperate during the procedure. It's not unusual for the patient to cough once the fluid starts to drain, because this is just helping with re-expansion of the lung. Post-thoracentesis, we need to watch the site, the puncture site, to make sure it doesn't continue to drain. The patient does need a chest x-ray post-thoracentesis, and this is to make sure that the lung has re-expanded and that the patient has not developed a pneumothorax. There are many videos on YouTube of a thoracentesis, and I would recommend that if you've not been able to see one, that you go ahead and watch one on YouTube so you have an understanding of how they are done. Okay, that's it for respiratory assessment, guys. Just remember, there are some additional videos that you need to make sure that you watch on my YouTube channel. They are the videos on ABGs and the video on oxygen therapy. Thanks.